Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, listeners. It's Lindsay Smith-Rogers, the producer of Public Health on Call. Today, gender and gender identity. Dr. Sari Reisner is an epidemiologist at the University of Michigan. He joins Dr. Josh Sharfstein to talk about the differences between the concepts of sex, gender, and gender identity, and why these differences matter for health. Let's listen.
Professor Sari Reisner, thank you so much for joining me today on Public Health on Call. How are you?
I'm doing great. Thanks so much for having me.
We're going to talk about some words that have fallen into disfavor right now in the current administration, gender and gender identity. Could you maybe introduce yourself to our audience as to why I called you about these words?
Sure. So my name is Sari Reisner. My pronouns are he and him. I'm an epidemiologist by training. My research focuses on transgender population health, as well as sex and gender-based research methods for epidemiology and the study of health disparities.
Great. Well, let's start with the word gender. You read various news stories or now website posts, and you see the claim that we should be talking about sex only and not gender. Can you unpack that a little bit?
Absolutely. So when we're talking about sex, kind of basic definition-wise, we're often talking about biology. We're talking about, for example, chromosomes, hormones, reproductive capacities and organs. And typically sex is assigned at birth based on typically the appearance of a baby and an infant's, genitalia. Gender, on the other hand, is the cultural and social distinctions, processes, norms that get mapped onto that biology. And gender is very contextually dependent. So, if you look across the world globally, there are different norms for men and women. There are different norms for people who may not identify as men or women. And importantly, gender is multidimensional. So it's not one distinct aspect. There are dimensions, for example, of gender expression, how a person manifests their gender, behaves, the clothes that they wear. There are gender identities, so a person, how they experience themselves and their internal felt sense of themselves in whatever gender they are. And there are gender roles, so a person does gender in relation to other people, if you will.
So let's talk about the health impact of gender versus sex. Sex and the chromosomes has an impact on health for sure. There are all kinds of illnesses baked into our genome. The X and Y chromosomes have all kinds of implications for health. How would you make the argument that gender separate from sex also impacts health?
Absolutely. So if you were to imagine, for example, a causal diagram, and you have, for example, sex leading to whatever your health outcome is, you imagine, I think, gender as being on the pathway. So it's not necessarily sort of a one-to-one correlation. So I think a good example is healthcare and help-seeking behaviors. So utilization of care. We do see differences on a population level between men and women, just generally, with generally men having lower rates of help-seeking than women. That's not a biological phenomenon that men are help-seeking at lower rates. Rather, that's a function of a gender. So, for example, norms around what it means to be a man, to be masculine, to be the traditionally not seeking help, needing to be independent and those kinds of things. So that's just one example, but certainly there are others. And when we talk about, for example, in the mental health domain, we talk about depression. On average in the population, women have higher rates of depression. Is that a function solely of biology? The studies suggest that there are complex both sex and gender pathways. Gender pathways could be, for example, the way that women experience the world, differential expectations that are placed on women. For example, for those who wish to have families or have families, and also careers and jobs, extra stress that may be associated with that and so forth. So to collapse sex and gender, without considering them distinctly, or at least without asking the research question of, are there sex and gender pathways both, is really to do a disservice to understanding health and well-being, and therefore interventions that might be leveraged to address them.
That's so interesting. Let's start with your first example there about men who don't want to go to the doctor. What you're saying, as I understand it, is that you're not going to be able to find on the Y chromosome a gene for not wanting to go to the doctor, but it may be in how being a man is constructed in our society. Is that what you're saying?
That's correct. Yeah.
And if we wanted more men, say, to get colonoscopies, for example, then the solution might not be like a medication to address the chromosomal issue or the presumed problem with sex. The solution might be something that really is tackling gender and trying to get people to realize that it's okay to be a man and have a colonoscopy.
Yep, that's correct. And it would also be in terms of, how we might focus our education efforts, right? What are the barriers that, for example, men face to getting a colonoscopy, which may be different to those that may be those that women face?
What's interesting to me is like these examples don't seem particularly highly politicized. I don't know that people would honestly believe that it's patterned on the Y chromosome, why, men don't get colonoscopies. And yet the term gender is turned into this political kind of football. Why is that?
Yeah, indeed. The distinction in sort of erasure of or collapsing of sex and gender is something that really goes against a lot of the science. So indeed it is something as being wielded in a very political framing that actually is not supported by the current scientific evidence. If we look back in epidemiology's history, there was a tendency to really collapse these two phenomenon, right? To think of them as one thing. And in the past 25 years or even 30 years, the field has evolved to identify points of intervention and unmet needs, as well as to understand the distribution of different health conditions across the population by both sex and by gender. And so this politicization really is setting us back. It really is setting back the science.
Let's turn to gender identity, which is, more politically charged these days because of the statement that the administration has made that there are only two sexes and we shouldn't consider gender identity at all. Talk to me about the health consequences of that.
So transgender people are individuals who identify differently, have a gender that's different than their sex assigned at birth. So these are people who may identify as transgender women or transgender men, people who may have a non-binary identity. They feel like it's not really fitting to be either men or women, or some combination of both in terms of how people are feeling. And we know on a population level, domestically in the US and globally, that transgender people face all sorts of health inequities in the mental health domain, including extraordinarily high rates of suicide. So there was a study of the US Transgender Survey in 2015, which showed a 40% of trans people had a suicide attempt rate at some point in their lives. Yet, this is not a biological imperative. This is really largely understood to be a consequence of a stigma, discrimination, and the experience of being excluded from society. So we have a variety of mental health disparities. And then for transgender people, relative to people who are not, also we see physical health disparities. So we actually see higher rates of asthma, again, which is a sort of stress responsive health condition. We see higher rates of HIV and infectious diseases. We also see higher rates of some chronic diseases. These disparities by gender identity, they exist, first of all, and we need public health efforts to address them. And the insistence and assertion by this executive order that says there are only two sexes and a veritable erasure of transgender people is, again, not consistent with the science, and it's not consistent with the inequities that we see in disease burden on a population level.
In other words, just like before, we were talking about gender being really important to understanding, for example, why men may not go to the doctor. Gender identity is really important to understand why certain individuals are at higher risk for suicide, mental health conditions, or other health challenges. And if you're not looking at gender identity, you're missing something that is genuinely important to their health and ultimately to public health.
Exactly. In the way that we similarly talked about the need to focus on potentially strategies that are gender responsive for men, in this similar fashion, we have a need to do that for transgender people. So The rates of avoidance of care or delaying care are much higher for the transgender population on average than non-transgender cisgender people. And so similarly, we would need public health efforts to really create spaces and address that barriers specifically that this population faces to be able to getting access to care. And of course, we know that preventative care and we know that urgently needed care are vital to actually addressing and improving the health of populations. So it's an imperative that we consider gender identity.
Seems like these executive orders and this view that gender and gender identity are terms that can't be used creates such a gulf with current scientific understanding, not only of health challenges, but about what to do about them.
Yeah, indeed, it really does. And there's a tradition in Latin American social medicine history that there's an epidemiologist, Neymar de Almeida Filho, who talks a lot about, he's Brazilian, and talks a lot about this phenomenon of epidemiology without numbers, that where there is no official, quote unquote, data or numbers, then therefore the problem doesn't, quote unquote, exist, right? And so this, I think, is very much, unfortunately, an example of that type of structural violence and exclusion that can happen when the state is effectively erasing a population.
But the problem still exists.
That is correct, yes. The problem is present. The language that is saying there are only two sexes and no gender is not accurate. It does not reflect the scientific world or the field of public health and the issues that exist for populations.
In a world where federal agencies are being told not to use gender and gender identity as terms, what does the future of science look like in this area?
It's a great question. So I think the need and the direction forward is really going to be to continue doing what I think now will be courageous science, courageous scholarship, because as we said before, the transgender people and gender still exists. And so what it's going to mean is that the funding streams may change, the availability of resources, but the research and the public health efforts to address population needs will need to continue. So we'll need to get creative, we'll need to get strategic. And by strategic science, I mean actually continuing to do the science. I think there are roles for many different actors. It's a time for us to come together across different sectors, not just in public health, but certainly in medicine, legal dimensions, economic well-being, and to come together and really build strong coalitions and enhance the coalitions that we already have. And so, for example, opportunities may look like a lot of medical organizations, professional associations, are not affiliated with the federal government and therefore can issue formal statements and therefore can support this kind of research that's going on. So the idea is to really engage a diverse array of stakeholders to be able to come together who are grounded in the science and in the evidence base that shows both sex and gender matter for health.
It sounds like what you're saying is that there's a lot at stake for health.
There certainly is. And the goal that we really need to have and put the stake in the ground is that we need to help people of all genders and all gender identities to thrive.
Professor Sari Reisner, thank you so much for joining me today on Public Health on Call.
Thank you so much for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Cesiri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Cesiri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.